The American Brain Tumor Association is pleased to welcome you back to our webinar series. Our webinar today will discuss Your Tumor's Personality, the Importance of Molecular Profiling. This webinar is sponsored by Agios Pharmaceuticals. My name is Umbreen Maan, Program Manager here at the ABTA. I'm delighted to introduce our speaker today. Dr. Brat is the Magister Professor and Chair of Pathology at the Feinberg School of Medicine and a member of the Robert H. Lurie Comprehensive Cancer Center at Northwestern University. He is a physician scientist who practices diagnostic surgical neuropathology and directs a lab that investigates mechanisms of glioma progression, including contributions from the tumor microenvironment, hypoxia, genetics, angiogenesis, and stem cells. One of his long-lasting scientific interests is in defining how hypoxia and necrosis develop within diffuse gliomas and determining how the tumor microenvironment is reshaped in response. Thank you for joining us, Dr. Brat. You may now begin your presentation.
Well, thank you for that very nice introduction, Umbreen. I'd also like to thank the American Brain Tumor Association for hosting this educational webinar. And I'd like to thank all of you for attending this webinar. It gives me a really great opportunity to discuss diagnostic neuropathology and the way we are now diagnosing brain tumors with molecular profiling and why that is really in advance and should be important to patients, their families, and their caretakers. So the title of my talk is Your Brain Tumor's Personality, the Importance of Molecular Profiling. I'll be giving this talk and then we'll hopefully have time for questions afterwards. I'll be highlighting the most frequent brain tumor in adults, the diffuse gliomas that include glioblastoma and medulloblastoma, the most common malignancy in childhood. I'd like to first start off at a fairly fundamental level and just discuss what disease is and what diagnosis is and how those are interlinked and really depend on platforms that we use to define diseases and diagnose them. So a disease is a deviation from or interruption of normal structure or function in any body part, organ, or system that is manifested by a characteristic set of symptoms and signs and whose etiology, pathology, and prognosis may be known or unknown. We have large textbooks full of diseases with their characteristics within them. Brain tumors is a chapter within each of these books. We even have books that give code numbers to each disease so that they can be classified, studied over time epidemiologically for their frequencies and increases, decreases, and hospitals and cancer registries use these to classify disease. The diagnosis is closely related to disease. It's the act of determining the nature of a disease through evaluation of patient history, examination, and review of laboratory data. Now, it's that laboratory data that we're going to focus on today. It's what pathologists have used to give diagnoses for over 100 years, but that laboratory data is changing dramatically to more refined molecular testing, and it'll continue along those roads. So again, we have textbooks in surgical pathology and in neuropathology that have more specific diseases with criteria for diagnosing them. Now, one thing I'd like for you to consider as we look at this piece of art by Rene Magritte, it's a picture of a pipe, and then underneath it, he says, "This is not a pipe." And what did he mean by that? He meant that, as he said, I can't use this pipe to put tobacco in. I can't smoke it this is not a pipe, this is a representation of a pipe. It's a piece of art that duplicates or tries to imitate a pipe, but it's not a pipe. And I'd like you to consider that as we go forward as well, and we think about brain tumors. Here we're looking at an MRI with an arrow pointing to a neoplasm. This is histology showing a glioblastoma. It is a 5-micron section of tissue that has been stained with hematoxylin and eosin, allowing it to be visualized as pink and purple. And this is a very sophisticated methylation array showing 1,000 different patient samples and how the DNA is methylated to different extents in each one. So I would say that each of these is not a disease either. These are representations of disease using different diagnostic platforms, okay? And we are trying to improve our representation of disease using diagnostic platforms as they progress over time. And using these more and more advanced platforms, we begin to understand the tumor better and better and better at a more, at a deeper level, hopefully, as we go forward. And we get to represent it, hopefully, in a way that is more and more clinically meaningful. And I want to go over how we have gone through that advance and where we are heading in the future in terms of representing brain tumors, patients with brain tumors, in a manner that they can be treated in a more personalized and successful manner in the future. So again, I want to reiterate that disease and diagnosis can be thought of as two sides to a coin almost. They almost always go hand in hand. Diseases are recognized by specific pathologic features. So that glioblastoma is characterized by infiltrating tumor cells through the brain that are very atypical. They look malignant, and there's necrosis and microvascular hyperplasia. Diagnoses are established for a disease by fulfilling criteria. In the traditional sense, that is adding up criteria that we recognize under the microscope for making a diagnosis and therefore defining a disease. Now, disease and diagnosis rely on platforms. If you want to think simplistically about this, you could say, well, hypertension is a disease. The diagnosis is made using a blood pressure cuff. That's the platform, and we make that diagnosis if the blood pressure is over 140, for example. Well, in that case, the diagnosis and the disease both depend upon a blood pressure cuff as the platform. For neoplasms, of course, it's a lot more advanced than that, and the platforms we're using to make diagnoses, they are changing, and they're changing dramatically over time. So defining diseases and establishing diagnoses in an era of precision medicine needs to be done in a very thoughtful manner. We need to do it in a way where a diagnosis and a platform provides a tumor or diagnosis that has a unified pathophysiology. The diagnosis has to be internally consistent across different testing platforms. We can't have one platform giving rise to one diagnosis and another one giving rise to another diagnosis. The diagnosis has to be defined by criteria that everybody understands and uses. It has to be reproducible. We've had a problem with that in the past. I'll give you some examples, but we want a patient with a brain tumor that gets a diagnosis in Los Angeles to not only get the same diagnosis in Los Angeles if it's re-reviewed by the same pathologist a week later, but also to be able to get the same diagnosis in New York City if another pathologist does the diagnostic testing. And it really has to be clinically meaningful. If we're going to provide diagnoses and a personalized one, it needs to have context within clinical management. It needs to be useful to clinicians to treat patients in the most successful manner. The significance and challenges of precision medicine are both substantial. If used correctly, these platforms that we use for diagnosis and defining diseases can provide mechanisms. They can tell us how these tumors grow and potentially identify targets that we can use for therapies. They'll identify biomarkers that may demonstrate prognosis, how well patients will fare or respond to different therapies, and that can be found in clinical trials. And again, the largest hope is that we'll find specific markers within a tumor that predicts a response to a specific therapy, hopefully because the marker that's identified is a target of therapy itself, or is a surrogate for a prediction of a response to therapy. Those are the grand ideas of precision medicine. I would say that we are advancing, I think, fairly well at this point in time. Of course, in brain tumors, we need to identify additional types of therapy that are effective in specific subsets, and we are always in the process of doing that. So let's go back in time to 1926. You can see that there is a book on the left published by Harvey Cushing, the man photographed in the lower left. He was a very famous neurosurgeon, and together with Percival Bailey put together this classification based on what's called HistoGenesis. The assumption is that specific tumors arise from specific cell types within the brain and recapitulate those normal cells, but in an atypical or malignant fashion. So the main point is that these were tumors that were identified under the microscope as having certain appearances. So an astrocytoma, for example, shown right here, had the appearance under the microscope of an astrocyte, whereas an oligodendroglioma had an appearance like an oligodendrocyte. The main point here is that we still use these terms today because they were defined back in the early 1900s, and they used the same platform for diagnosis of disease that we used until essentially 2014 or 15, and that's the microscope. So this is a classification that started based on looking at tissues, tumor tissues, under the microscope and making classifications of glioblastoma, astrocytoma, oligodendroglioma, and some of the more common tumors like medulloblastoma of childhood as well. And like I said, we used this up until the 2007 classification by the World Health Organization, which didn't change until 2016. So we used that classification essentially until 2015. And we classified tumors by the way they looked under the microscope. I'm going to talk about the diffuse gliomas, the most common primary tumor family of adults. We define them as astrocytomas because they look like astrocytes, and we grade them based on features under the microscope. We diagnose other tumors by looking at the tissue sample under the microscope as oligodendroglioma of grade 2 and 3. And then for a long time, we said, well, we can't distinguish these tumors precisely, and some appear to have both cell types, and we'll call those oligoastrocytomas. Grades 2 and 3, again, based on the way they look under the microscope. So the way that happens is that a patient develops symptoms, perhaps seizures, gets brought into the hospital, eventually will get an MRI that shows a lesion like this. That will be either resected or biopsied, and the material is sent to pathology, where we make a thin tissue section and stain it. and look at it under the microscope and say, well, that looks like an astrocytoma, and then we'll grade it. Or that looks like an oligodendroglioma. It's got these small, round, regular nuclei and these white halos around it. That looks like an oligodendroglioma. Or an oligoastrocytoma, because it looks like, well, this one has these oligodendroglioma-looking cells, but also the astrocytoma-looking cells. So that's a mixed lesion. You can think of this, I think, relatively crudely as a person witnessing a crime. There can be some subjectivity to what one person sees and what another person sees. The goal, I think, would be to get DNA evidence for a crime. So it's the difference between a visual assessment of a tumor and a molecular assessment, and this is a visual assessment. The problem with microscopic diagnoses is that there was a lack of reproducibility. There was inter-observer variation, so that a pathologist in Chicago may not agree with the pathologist in Los Angeles or New York. And as I said, with precision medicine, we really need to have reproducibility criteria that we can depend on, and to be able to give a diagnosis that was clinically meaningful. Essentially, the neuro-oncologist and neuro-oncology community had lost a bit of faith with the neuropathologist because we did not have good inter-observer agreement based on microscopic examination, and clinicians were frustrated because they would treat patients differently with specific diagnoses, as they've shown here. Given a little bit more evidence to this lack of reproducibility, if you look at these tumors that have been diagnosed by morphology under the microscope, you can see that glioblastoma has a very distinct and poor outcome as a diagnosis, but the other diagnoses all seem to have intermingling in terms of their outcomes. That basically implies that the diagnoses that we have been giving didn't predict a specific outcome clinically, and therefore it wasn't as useful in directing therapy. We had a long way to go. The first major step towards precision medicine actually had to do with recognizing that we couldn't identify different molecular subsets of gliomas under the microscope. The identification of IDH mutations in diffuse gliomas was a huge finding. The presence of an IDH mutation, as determined by DNA sequencing, was found to be associated with patients that were younger, patients that had diffuse gliomas that progressed slowly and became secondary glioblastomas, and overall the tumors had a better prognosis than those tumors that didn't have IDH mutations. And you got to ask the question, well, how come a mutation gives a better prognosis? These tumors, the IDH wild type gliomas, have mutations, and they actually have more of them. They just don't have the IDH mutation, which recognizes a disease that has a slower progression. So IDH mutations within a patient with a glioblastoma has a much longer survival. An IDH mutation in a grade 3 tumor actually has a much better prognosis than a grade 3 tumor without an IDH mutation. And surprisingly, even those grade 3 tumors that do not have an IDH mutation have a much poorer prognosis than those grade 4 tumors that do have a mutation. So now we recognize that we were talking about really two different diseases, IDH mutant gliomas and IDH wild type gliomas, and that was really brought home by large-scale molecular testing that I'm showing you. This is a very sophisticated way of looking at brain tumors. It's looking at how their DNA is methylated. But this could be gene expression, this could be proteomics, this could be chromosomal alterations, we're looking at 1,000 different tumors here in columns, and the rows are the methylation profile with blue and yellow and red recognizing different levels of methylation. Using any of these platforms, these tumors get subdivided into two subsets very cleanly based on the presence or absence of an IDH mutation, isocitrate dehydrogenase mutation. I think driving home the fact that we could not recognize two distinct diseases under the microscope. The next major finding had to do with pediatric brain tumors that were diffuse gliomas. There are these tumors that occur in young children that arise in the pons and thalamus, both midline locations, and they're very high grade. And those specific tumors in those specific locations were found to have a high frequency of these mutations in the histone H3 gene. And it was also found that these genes only occur in those types of tumors that have very high grade behavior and could be used to define the tumor as grade 4 or the highest grade. Now, interestingly, the type of H3 mutation that arises determines where and at what age and the clinical course of that disease. So that if the tumor has a H3 mutation in the K27 location, coded in green here, it's going to be localized to either the pons or to the thalamus. It's going to occur in younger children, and it's going to have a very poor outcome. If the H3 gene is mutated at the G34 location, the tumor is going to arise up here more in the cerebral hemisphere at a slightly older patient population and be associated with a slightly improved prognosis, but still poor. Another important finding was that not only does the K27 versus G34 location make an impact on tumor location and clinical progression, but the co-mutation with those H3 mutations also determine where in the neuroaxis these tumors arose. So that a tumor that has a K27 mutation and an ACVR1 mutation occurs specifically in the pons, whereas co-mutation of others may direct this to other locations within the central nervous system. So when I was in medical school and we learned about glioblastoma, we would be given these frequency distributions that looked like this, and they showed that the biggest peak for glioblastoma was in adulthood at age 67, 80 years old. But there seemed to be another peak at age 30 to 40, and still another peak in the childhood years. Well, now we know why that is. We know that there's IDH wild type glioblastomas that have a peak incidence in the 70s or late 60s. We have IDH mutant gliomas that occur in the 30s and 40s and progress slowly. And there are histone H3 mutations that occur in high-grade gliomas in childhood. So we're now understanding that those tumors that were recognized as similar under the microscope are very different in patient age, clinical behavior, and genetic makeup. And that, in its essence, is precision medicine. Now, the type of tumor that you've probably heard the most about is called glioblastoma, and it's the one that does not have IDH mutations. We call that IDH wild type. It just means IDH normal, if you will. These tumors are recognized by contrast-enhancing central necrosis, rapid growth, pseudopalisading of cells around necrosis, and new vessel growth, or angiogenesis. These are the tumors that have the poor prognosis. It's the tumor that Senator Kennedy had. It's the tumor that Senator McCain had. It's the tumor that Beau Biden had. They have a very, poor outcome despite surgical resection, radiation, and chemotherapy, unfortunately. We know a lot about their genetic makeup now. A lot of the next generation sequencing panels that have been used to define these tumors in large studies have shown that a wide array of genetic alterations can be seen within them. They happen to fall within 4 families: the receptor tyrosine kinase family, the p53 family, the retinoblastoma family, and then the TERT promoter mutation that leads to TERT activation and an escape from cell death or senescence. So you will begin to see, and probably have seen in the past decade, these genes be incorporated into brain tumor diagnoses. And this represents a major step forward. We are typically doing this type of sequence analysis or molecular profiling on just about every diffuse glioma now, and using this information not only in the report, but to establish the diagnosis. The hope is that in the future, by knowing these molecular alterations, we can specifically target them. We in the brain tumor community are always hopeful that, for example, there'll be a specific agent that can target EGFR or PDGFR, A or c-MET. Those are, a long time in coming, but that is the specific idea for personalized medicine in general. So based on all of that research in the past decade or two, we have become more sophisticated, and the WHO now breaks glioblastoma into specific entities based on the molecular profile as glioblastoma IDH wild type, glioblastoma IDH mutant, and then there's this specific midline glioma that often occurs in children in the pons and thalamus that is defined by its H3K27 mutation. So these have been incorporated and now form the basis for our diagnoses. For the lower grade gliomas, those that appeared to be histologically grade 2 and 3, astrocytomas and oligodendrogliomas, there was a lot of advances more recently in 2015 that led to us to use molecular profiling to diagnose these diseases more specifically. And really, this took another step into going from a morphologic diagnosis based under the microscope to a molecular profile based on IDH mutation, 1p19q codeletion, and ATRX and p53 mutations. So this is just the result of the TCGA analysis of histologically grade 2 and 3 diffuse gliomas, those tumors that were not glioblastomas but looked under the microscope like they were lower grade. And the take-home message was that it was much more predictable and much more reproducible to define these tumors based on the presence of IDH mutations and 1p19q codeletions to define diseases than it was based on morphology under the microscope. So we now define oligodendrogliomas as being IDH mutant and 1p19q codeleted. They also have an abundance of these other mutations that are listed over here on the right. Those tumors that are IDH mutated but don't have that 1p19q codeletion, they tend to have p53 mutations and ATRX losses, and that's now how we define IDH mutant astrocytomas. Those tumors that looked like they were IDH mutant, that looked like they were histologic grade 2 and 3 but didn't have either an IDH mutation or 1p19q codeletion, they were called IDH wild type, and they essentially have the same molecular profile as the IDH wild type glioblastoma. Carrying this one step further, it was recognized that these tumors that looked lower grade under the microscope that had the same molecular profile as IDH wild type glioblastomas actually had the same clinical outcome as glioblastomas. So that there's a subset of tumors that we thought were grade 2 and grade 3 that actually were grade 4 based on our current knowledge of molecular profiling. So that as well has been brought into the World Health Organization. And for these grade 2, grade 3 tumors, we're now recognizing them as IDH mutant and IDH wild type. And we're defining oligodendroglioma based on their molecular profile rather than under the microscope. So your surgical pathology reports that you receive after a biopsy and or surgical resection from the pathologist are looking very different today than they used to. We're using what's called an integrated diagnosis that uses histology, that determines a grade, and integrates molecular information both into the grade of the tumor and into the diagnosis. So that is a major change from the last 100 years that is improving our understanding, our diagnosis, and our treatment of patients with diffuse gliomas. The other test that you'll almost certainly hear of if you, your family member, or the patients you're taking care of have a diffuse glioma is MGMT. If you ask neuro-oncologists, it would be the first or second test that they would ask for in a patient with glioblastoma. It stands for methylguanine methyltransferase, MGMT, methylguanine methyltransferase. And it's important because it predicts response to chemotherapy. Those tumors that have a methylated MGMT or don't express MGMT have a much better prognosis following chemotherapy than those that don't. So the reason for that is that MGMT as an enzyme undoes the effects of chemotherapy. So if you have an enzyme that undoes the effects of chemotherapy, it's not going to be as effective. Whereas if you silence that gene by methylation of its promoter, then the chemotherapy is going to be much more effective. So this is really called a predictive test. It predicts if you're going to be responsive to chemotherapy if you have a glioblastoma. And it's an important part of molecular profiling of glioblastomas in particular. So I'm just going to follow up and finish up with a brief discussion of medulloblastoma, grade 4. Again, the most common primary tumor of childhood. It is highly malignant and it's primitive. What we have found is that even though they have a poor prognosis overall, there are some favorable and unfavorable variants. Very much like the diffuse gliomas, in the past we have classified these by what they look like under the microscope: a classic variant, a large cell anaplastic variant, a desmoplastic variant, and an extensive nodularity variant that looks very much like this, but just more extensive, as the name implies. This did have some clinical meaning. We could stratify risk based on morphology fairly well. Again, we couldn't direct therapy very specifically to morphology-based classifications, but this did, in fact, have some clinical utility. However, these large molecular profiling studies that looked at gene expression and methylation profiles showed that there were clearly 4 different biologic types of medulloblastoma: those that were driven by the Wnt pathway, the sonic hedgehog pathway, and then group 3 and group 4 that were clearly distinguished from these 2 pathways. And you can see this clustering of these tumor types based on their molecular profiles. Well, it turns out if you group medulloblastomas into these 4 molecular groups, you'll see very distinct mutations within each group as well. And there's a specific clinical profile of each of these subtypes with differing patient ages, different biologic progression, and again, hopefully different therapeutic regimens based on this personalized approach to diagnosis. This again has a lot of utility in that, for example, the Wnt pathway medulloblastomas have a very good prognosis, so much so that the therapies, especially the radiation doses, are beginning to be reduced for these Wnt pathways. There's also specific targeted agents to the Wnt pathway and sonic hedgehog, and they hopefully will be developed for the non-Wnt, non-sonic hedgehog pathways with the worst prognosis as well. So this has come a long way as well. We are now not just diagnosing medulloblastoma, but we're diagnosing a Wnt pathway medulloblastoma, sonic hedgehog pathway, group 3 or grade 4, each with its own clinical features, each with its own molecular profile, each with its own targets for future therapies, and each with its own prognosis. So in the WHO as it exists now, we've added molecular subsets in addition to histologic variants, again, introducing a new era. So the diffuse gliomas and medulloblastomas include multiple genetic entities. We're no longer diagnosing tumors under the microscope. That was the platform that served us well for 100 years. We are now entering the molecular era. Diseases are now diagnosed and treated in a manner that incorporates molecular properties that also reflect their clinical properties. And diagnoses are more clinically meaningful, reproducible, and guide therapeutic options. We continue to develop better and better platforms for improved and more personalized diagnoses, and we're learning more every day about this. So with that, I would like to thank you very much for sticking with me. I do apologize for the interruption, and I'd be glad to take any questions.
Thank you, Dr. Brat. We will now take questions. If you have a question you would like to ask, please type and submit it using the question box in the control panel on the right-hand side of your screen, and we'll answer questions as time allows. Dr. Brat, one of the questions we have here is asking, does molecular profile tell a patient if their tumor is hereditary or if it's something that they can pass down to their children?
There is a way on molecular profiling to tell if your tumor is inherited. If you think about you inherited one gene from your mother and one from your father, in a typical glioblastoma, for example, only one of those genes gets mutated. If both of those genes are mutated, that may indicate you were born with one and then developed the second mutation. So on the molecular profile, the sequencing, if the mutation frequency is near 100%, that means all of the genes within that tumor, not just 50% from your mother or father, that would indicate that that could be a hereditary tumor type. But very good question, and that can be identified if the sequencing includes that gene that was inherited or the one that you may pass on. It's important for you to go over the molecular diagnosis with your neuro-oncologist and ask those questions.
Thank you. And can molecular profiling be used to determine the effectiveness of diet or other holistic methods on preventing tumor growth?
Not to my knowledge at this point. Those studies have not been done. Molecular profiles are being studied in all sorts of clinical trials now, and the alternative approaches that has been questioned could be studied in the future if the molecular profiling has been built into that specific clinical trial.
Thank you. And can you explain the role of molecular profiling during tumor progression or reoccurrence? Is it necessary for the patient to have repeat sampling done or repeat analysis done in order to understand mechanisms and the best mode of treatment?
That's a very good question as well. What we are finding out from repeat molecular testing at the time of recurrence is that many of the genes that are altered in the primary tumor are also altered in the secondary tumor of the recurrence. For example, IDH mutations are almost always present in the second tumor as well as the first. However, the act of chemotherapy and radiation therapy and just tumor progression will often lead to additional mutations, additional genetic alterations, and the hope is some of those may be treatable in the future. In fact, there is some evidence that IDH mutant tumors may acquire even more mutations following chemotherapy. It's not clear if that is clinically significant or not, but again, the hope is that we can use that finding to make the tumor vulnerable to therapy.
Thank you. And can you talk a little bit about how molecular profiling is used to inform research and lead to advancements in treatments and development of new clinical trials?
Yes, another wonderful question. Until we have defined the different molecular types of gliomas, I don't think we have much of a chance of advancing the therapies. In breast cancer, for example, you may have heard of HER2 positive tumors. It only accounts for 20% of breast cancers, but those specific breast cancers are exquisitely sensitive to targeted therapy to HER2. We need to have those molecular subsets identified in medulloblastoma and in glioblastoma in order to identify therapies that would be expected to hit those targets identified by molecular profiling. It's really at the heart of clinical research. It's really at the heart of doing smart, evidence-based clinical trials that have a hope of effectiveness for the future.
Thank you. And we have time for just one last question. Some patients may have had surgery of their tumor in the past, during which samples of the tissue were saved. Is there benefit to the patient in going back and having an analysis of their samples conducted again? And do you know how long these samples are kept for?
Typically, they're kept for at least 10 years at the institution that did the biopsy or resection. And I would think that it would be useful to get more contemporary molecular testing. It typically would be successful. A lot of times these biomolecules do degrade slowly over time, but as long as there's enough tissue left in the sample, the testing could be done. I would expect that if you were to go to the hospital and ask for the tissue, you would be able to obtain it and you would be able to get molecular profiling. I think that would be something you would want to talk to your neuro-oncologist about.
Wonderful. Well, thank you, Dr. Brat. That is all the time that we have for today. Thank you all for joining us, and thanks once again to Dr. Brat for your wonderful webinar presentation. Aside from our educational webinar series, the ABTA has a variety of programs that help support patients and caregivers throughout their experience. For more information about ABTA's programs, events, and services, visit ABTA's website at abta.org, email us at info@abta.org, or call the ABTA Care Line at 1-800-886-2282.